Okay, we're now live. Hi, Elliot Fishman here. Today is February 5th. Hope everybody is doing well. It's going to get cold again in the East Coast, but no snow. Baltimore, we still have all the snow that came the first time. No one cleans the streets, no one cleans the sidewalks, no one cleans the roads. Everything is one lane. It is not pretty. If you need some snow, give me a call. Baltimore has plenty of snow to give to you. Anyway, it's cardiac month, February, so I thought I'd mention a little bit about cardiac CT. One of the things I think most of you also experience is that cardiac CT is growing and growing and growing. Take something as simple as calcium scoring. Internists, everyone is using it as part of the triage of patient workup. And so we do probably 10 to 15 cardiac calcium scores a day in the outpatient centers, and that continues to grow. We do lots of coronary CTA. Coronary CTA is better paid now, reimbursed, than it used to be. And it is the standard of care, whether it's in the ER setting, whether it's a patient with vague chest pain. We do not only the ER, which was everything we used to do, but do a lot of them on inpatients, which is the same thing, but do a lot of them on outpatients. Okay, again, cardiac CT has become the gold standard. There are companies that do further analysis. I won't go into that today. Maybe it's something to speak about at a different time. HeartFlow is one of them. Clarily is another one, two very good companies. Now, in terms of cardiac CT, we also know that pre-medications are very critical. We have some comments about that on our protocol page, and we'll need to update that. But also you recognize that the scanners, the faster the scanners are, the better the scanners are, the better the quality of the images. And so things like photon CT are particularly good for looking, and so being able to separate out calcium from lumen, being able to do analysis become very, very important. Lots of work being done trying to understand better about the importance of plaque and where it's located and quantity, and trying to use a lot of the information as predictors for outcome and management. Whether you're taking statins or not, or other cardiac medications, everything seems to be dependent on your coronary scoring and your coronary CTA if you get one. Majority of patients do not get coronary CTA. People will be treated based on the calcium score, typically for statins, but if there is an issue with chest pain or anything else needs to be further investigated, I think you will see the coronary CTA. So most places have a few radiologists who read them. You need to be really good at it. You need to really take an exam, be certified in cardiac CT. That's been done for many years. There are many review courses that you can go to, learn how to read the studies. For the technologists, we have great techs, how to perform the studies, okay? It's not just doing an abdominal or a chest CT. It's timing, delivery of contrast, acquisition. Everything needs to be perfect. Heart rate needs to be perfect. It's the most challenging or demanding study, but again, the better the scanners get, the better the coronary CTAs will get. In terms of also cardiac, we do lots of cases for aneurysm, rule out dissection, look for extensive dissection, follow-up of dissection, follow-up repair, preparing for TAVRs, preparing for stenting, looking at follow-ups from stenting, looking for complications, looking for changes in size, smaller or larger. We do lots of vascular runoff studies. So in that cardiovascular space, CTA is really what's done routinely. Bone removal, you can do some calcium removal as well. So what you're seeing is in the cardiovascular space and cardiac space, things are growing, and it is one of the biggest growth areas. Again, you need good scanners. If you have so-so scanners, it's probably not going to be really valuable, because you're going to have a lot of non-diagnostic or not perfectly diagnostic studies, which will either lend you to go to cath or repeat the study or just treat the patient empirically. So quality is everything. Radiologists are mostly the ones doing cardiac CT now. There's some cardiologists doing it, but those fighting days are over. Everybody is way too busy. I think the reason radiology won in part, we did a great job, but also in terms of throughput, in terms of imaging centers, you can't just do cardiac CT. You need to do everything, and that's how we do it in our outpatient centers. I'll update some of the stuff on cardiac CT. We have a lot of new cases, but I'll update some of the protocols. And February is a great month. Happy Valentine's Day, which is why it's Cardiac Month. And that's February 14th. A lot of famous people are born in February. Lincoln and Washington, the two I can think of. But with that, I'll wish everybody a great day. I'm reading films, reading 3Ds, reading a bunch of vascular stuff, and we'll see you later, everybody. Have a great day.